Morning, everyone. My name is Shivendra Kumar. I'm a cardiac physiologist here in London Northwest University Hospital. Um, Thank you very much, Sahil. Thank you very much, Parallel University, for giving me this opportunity to do a presentation on topic hemodynamic assessment of cath lab procedures. So, before we begin, Sahil, may I ask if everyone has joined and we are ready to go?
So few are left. They will be joining soon.
Sure. Okay. So,
You can start, sir. You can start with the basics.
all right. Um, so we are going to discuss this topic about hemodynamic assessment of cath lab procedures. Um, this is a very old presentation I made during my college days, and I used to study and present as well. So I'll be covering few topics in here: why we do, what is hemodynamic monitoring, and what are the roles of hemodynamic monitoring, what is the purpose, what are the factors, how about transducer, how about hemodynamic data. We will be discussing everything in detail. So basically, hemodynamic monitoring is a very important part. You can say that it is an integral part of uh, cath lab procedures. Any cath lab procedure, you cannot do a procedure without hemodynamic monitoring, and it works hand in hand with all the other modalities. Like for any procedure, you definitely need vitals to be there on screen to be more comfortable with the patients and perform the procedure. Okay, so as you know that any inadequate equipment during cardiac catheterization is a contraindication for any procedure. Okay, so you can see that how important is this. So what is the role of hemodynamic monitoring? Why you need this? So it is very important to diagnose various cardiovascular diseases such as pericardial disease, valvular disease, congenital heart disease. Now, when we say congenital heart disease, back in days when the echo was not very advanced, the most important tool for any diagnosis was this hemodynamic monitoring and hemodynamic assessment. Okay. Um, Pericardial diseases, because at that time the CT and MRI was not very much developed. They used to see the pressure in every cardiac chamber, especially the ventricles, and they used to diagnose if this patient is in any form of constrictive pericarditis or restrictive cardiomyopathy or any sort of other cardiomyopathy. Okay, then any pericardial tamponade or anything else. So also, this is most important part of monitoring when we do a procedure like balloon mitral valvotomy, called as PTMC, or balloon aortic valvotomy, or anything, any balloon procedure, any therapeutic procedure which we do. This is important because we check the gradients between the two chambers, and this is only possible with the hemodynamic data. So as I told you that before the echo existed, this was the first tool to diagnose any form of cardiac disease. Um, then day-to-day life, day-to-day procedures, we also do a quick LV and diastolic pressure check during the angiogram, and this is important in patients of severe LV dysfunction. We want to know that how much is the end diastolic pressure is raised for patients. This is important for finding out the diastolic heart failure. Okay, so various roles. Now, what is the purpose of this? So we measure intracardiac pressure, we assess intracardiac blood flow, how the blood flow is moving from one place to other by calculating the oxygen saturation in it. Then we assess ventricular function, as I told you, that if the LV and diastolic pressure is very high, that gives an idea that this patient can have an LV dysfunction. Or even if the echo is normal and if you get LV and diastolic pressure high, then this can be a sign that this patient is going into an heart failure. Or if the LV and diastolic pressure is high and in echo, you get normal LV ejection fraction, then this can be a heart failure with preserved ejection fraction. Okay. Then to determine cardiac anatomy, this is important. I'll explain you how this is important in determining the cardiac anatomy in later slides. And to assess the valvular function, of course, we do check gradient between the cardiac chambers, and then we see how much is the pressure difference between both chambers. Then to assess pulmonary and systemic circulatory system, there is something called as QP by QS, which is to measure the systemic versus pulmonic ratio, and this is important to see in patients of congenital heart disease. Okay, and then any intracardiac biopsy, we need hemodynamic monitoring, and then intravascular ultrasound. So we will discuss what are the factors which can influence hemodynamics. Now, very importantly, cardiac output. Now, if you have a good cardiac output, you will have a good pressure. Okay. If you have low cardiac output, the pressure will be obviously low. And if pressure in cardiac chamber is low, that will be an non-diagnostic pressure for any sort of other things like valvular heart disease or any other things. Then circulating fluid volume. Now, if a patient is in hypertension, if you give fluids, then the pressure will raise up. Okay. If a patient is receiving any other fluids, there will be change in the pressure waveforms because of the temperature change. Because body temperature is 37 degrees Celsius, but you give saline which is kept in theaters and which is cold, and sometimes change in temperature causes the variation in hemodynamic pressure recordings. Then respiration. On table, many patients are comfortable, but lot many patients are not. So they breathe heavily, they are nervous, and this will give you some sort of respiratory variation. So with your inspiration and expiration, you will see a difference of at least 5 to 10 mmHg in their systolic pressure. Okay. Then there is vascular diameter and resistance. If there is increased peripheral vascular resistance, the pressure will fall down. So we need to make sure that we are reading pressures correctly, especially when we give GTN. So any patients, when we give glycerol trinitrate, we give this intracoronary, we have to monitor the pressure carefully at that time. We should not panic that, okay, pressure is falling down suddenly. No, this is an effect of glycerol trinitrate, which is seen in the monitor that the pressure is going down. It takes about a minute or so to recover. Okay. Then blood viscosity. Blood viscosity is also matter. So if your blood is very viscous, the pressure usually we see is higher, at least 10 mmHg higher. Okay. Um, any questions still here? So we'll go ahead. Then we have hemodynamic monitoring equipments. Every cath lab should have this equipment. Without these equipments, we should not do any cardiac procedures. Very importantly, transducer, monitor, fluid filled catheter, tubing and flush system with a pressure bag. So I'll show you how the transducer works and monitor and the fluid filled catheter, why it is important. Now let's talk about pressure transducer. So transducer is basically a device which converts one form of energy to the other form. In this case, it converts the pressure energy to an electrical signal. Now, if you all know that pressure in artery is pulsatile. Now that pulse is sensed by this transducer. The frequency of the pulse is sensed and the pressure of the pulse is sensed. Lower the pressure, lower will be the electrical signal. Higher the pressure, higher will be the electrical signal. And that's how it works. And that's how it gives us the pressure. So in patients of high blood pressure, it is sensing the high pressure on the transducer at the transducer level. And that's why we are getting the high electrical signals on the monitor. When the pressure is low, it is not creating enough pressure inside the transducer system, and hence we get low electrical signals. And that's how the readings will be very accurate because artery system is a pulsatile system. All right. So there are several types of transducers such as reusable transducers, disposable transducer, and catheter tip transducers, which is now in more um, usage. So back days, there were reusable transducers like we used to not change the transducer for every patient. We used to use one single transducer for every patient. Disposable transducer, these are the transducers used in intra-aortic balloon pump, which is always fixed for one patient and then we can discard it. Catheter tip transducer, nowadays this is more in usage, especially with advanced IBP machines. We are getting IBP catheters with a tip transducer, with the transducer at the tip of the balloon. So this is now new advance where the transducer is at the tip of the catheter. So we get pressure right from the point where the catheter is located. Sorry, can we mute that, please? Transducers must be properly balanced and zeroed at the mid chest level to get accurate pressure measurement. Okay, so any transducer you want to use in cath lab, it has to be properly prepared. Okay, we'll talk about how it should be prepared. Okay, uh, improper balancing. This is very important. The transducer should be balanced or should be zeroed to the room air. Okay, and improper balancing, the electrical signal gauge will cause errors. Okay, so always you should open the transducer to air and then balance it, otherwise you will get false signals. Okay, too low the transducer position, it will cause higher the signal. Higher the transducer position, it will cause lower the signal. So the placement of the transducer should be not more than 10 centimeter higher than the chest wall. Okay, then zero referencing and leveling. So if you see a hemodynamic monitor, it will have a scale 0, 100, 200, something like that. So most of the authors suggest that the transducers must be zero at mid chest level. Okay, when we are in cath lab, we should make sure that our transducer is properly placed according to the patient's position. Okay, if patient is not able to lie supine for any reasons, like patients with pericardial tamponade, they are very tachypneic, they are very dyspneic. In those conditions, we have to make sure our transducer is moved up to the mid axillary line until we reach their mid chest level. Okay, now if you see this diagram, you will see on the top, um, the, at the top, the pressure transducer is located lower from the mid chest level, and hence there is positive hydrostatic head of the pressure, and then you will get a higher pressure because the fluid is creating a pressure going down because of the gravity. Okay, and you will get at least 6 mmHg higher pressure. Okay, and if you place a transducer above the mid chest level, then you will get a lower pressure of at least 6 mmHg to 10 mmHg more because there is negative hydrostatic head of the pressure. Okay, so because the fluid is not fluid is taking a lot of time to reach this transducer, hence it requires some pressure, and that pressure will be reduced because of this line, and that is called as negative hydrostatic head of the pressure. So hence you should always place your transducer at the mid chest level of any patient to get an accurate reading, and make sure that your reading is balanced, or you can say zeroed, before we record any pressure measurement. Okay, now we move on to The next slide. So we should always have a scale come stand which is movable, and we should be able to fix the transducer according to the patient's body mid chest level. Okay, so when a patient is lying flat, you should be able to see where exactly the mid chest level is lying. Mid chest level is the position, and then there you can place your transducer. Now it is very important to have a stopcock between the patient's line and the transducer, because this should be open to air before we record the pressure. Okay, if this is not done properly, we will get a false pressure. Sometimes you may not see pressure in the monitor because the pressure is either the lower the range of 0 or higher the range of 200. Okay, now it is very important for a good cardiac technologist to troubleshoot any problem during the procedure. Okay, it is it is important to know what are the things, but it is very important to know how to solve the problems, because is that is the key role you play in day-to-day activity in the cath lab. Okay, so I will discuss few problems during the pressure recording and how to rectify those problems. Now, first problem, you will see that there is no waveform in the monitor on the monitor. First thing first, check the power supply. Some of the transducers, they work with power supply, so you need to check if the transducer is getting enough power supply. Okay, then second, if there is no waveform, you check the pressure range setting on the monitor equipment. This is very important. You might be at the lower scale. Let's say you're recording an aortic pressure. Now, normal aortic pressure is 120 over 80. So you need a higher scale between 0, 100, and 200. But if your scale is maximum of 50, you may not see that aortic pressure because that is above the range. So you should always get a proper scale to get the recording. Okay, so always check what cardiac chamber pressure you are recording and whether the pressure scale is very important, the pressure scale is accurate for that particular pressure or no. Okay, then check the zero reference and the calibration of the equipment. Any pressure transducer, when we say zero or open to air, that is called as calibration of the transducer. Your calibration, before you record any pressure, the transducer should read 000. Okay, systole 0, diastole 0, and mean 0. Once it is leveled to 0, then you can open the stopcock, open the transducer, and read the pressure. Okay, if this is not done properly, again you will have a lot of problems. Then if you are not getting any waveform and you have got all these things correct, then you might have a loose connection in the pressure monitoring line. So always check if your pressure line is connected properly. If it is not connected properly, you may either get a false reading or you may not get a reading. Okay, then next is to check to be certain that stopcocks are not turned off to the patient. Okay, sometimes you will zero the pressure but you forget to open it to the patient side, and at that time you will not get the pressure. So if you are not getting waveform, check if the circuit is towards the patient and not towards to the air. Okay, so your circuit is very important. And then be certain that the connecting tube is not kinked or compressed. Now all these things before we discussed has been sorted, still you are not getting the pressure, then there might be a kink or connecting tube is not connecting tube is compressed. So kink in catheter or the connecting tube is compressed, and hence there is no flow or no connection between that kink, and then there is no pressure in the waveform. You remember that we record pressure in a very fluid filled system which is very clear. There should not be any kink, no blockages. Okay, then it is possible that the catheter is occluded or has moved out of the vessel. Okay, now you may be recording cardiac pressure, but the catheter has moved out of that particular chamber and hence you are not getting the pressure. Other possibility, as you know that every procedure we perform, we have to give a heparin because we are putting foreign body inside, like catheters. Now, if there is no proper anticoagulation, there is a possibility that there can be a development of clot inside the catheter. And once there is a clot inside the catheter, that is kind of a block, and hence you may not get a pressure. But if this is suspected, you have to aspirate, take it out, aspirate. Do not flush it inside. What happens when you flush it inside? If it is a clot, that will go inside the patient's heart. It can go anywhere in the system. It can go in lungs, it can go in coronary arteries, it can go in brain, any other organ. Okay? So it is very important to not to flush inside. You have to aspirate it outside. You have to do the suction outside. Okay? And be very gentle with this pressure transducers. You should never use a syringe to aggressively flush any hemodynamic monitoring line. For flushing, you should always use a pressure bag because it gives a constant pressure and constant flush with the transducer. What happens when you use a syringe? When you use a syringe, you are applying a pressure yourself, and transducer is not meant for receiving that kind of pressure by your hand. At that time, the pressure may go above the range of the transducer, and your transducer will get bursted inside, and hence you will not get pressure properly. Okay. So when you get no waveform on the monitor, these things has to be done step by step to see if you have troubleshooted the problem. Okay. Then if you get an artifact during the recording, artifact means your pressure waveform is not very smooth. You are getting lot of signal interference. Okay, then check for any electrical interference. Nowadays, when we do a intense procedure where the patient is in cardiogenic shock or any other or patient is on ventilator, then he might have got lot of syringe pumps, lot of medicines going on. Okay, these these equipments will have electrical connections, and these equipments will cause the electrical interference for our transducer. Hence, we should make sure that there is proper earthing, and that will solve your problem. Okay. Then check for patient movement. Okay. If you get an artifact, don't panic. Check if your patient moved from one place to other, because as you know that in cath lab, patients are not fully sedated. They are awake because the procedures are done under local anesthetics. So we should make sure that the patient did not move, and if it is moved, if the patient moved, the artifact was because of the patient movement. Okay. Then if you are getting artifact, then there can be a catheter whip and maybe the problem. So especially pulmonary artery catheters. Now when we record pulmonary artery pressure, and especially with balloon tip catheters, what happens is the catheter is small but the artery is very big, and with the blood flow the catheters move like a pendulum, like to and fro motions. When the catheter move with the blood flow, to and fro motions, you may get artifact on the screen. Okay. Then you have to make sure the catheter movement is very stable. The catheter is very stable. Can we mute that, please? You have to make sure that the catheter is very stable when you're recording a pressure. Okay. Then do hemodynamic response test. Okay, do hemodynamic response test to determine underdamping. So what is hemodynamic response test to determine underdamping? Now you have to make sure that your catheter line is flushed again, and you check again. If the pressure waveform is same, then that is your pressure. Then there might be a possibility that you may get rid of this artifact after flushing again. Okay. And then use alternative method of measurement when possible, such as arterial cuff, non-invasive blood pressure. So sometimes if your hemodynamic monitor is not showing proper pressure, just do a non-invasive blood pressure to double check if the pressure is same. Okay. Then waveform drifting. If there is a waveform drift means there is lot of movement across the pressure. It is going up and then it is going down, up and down. At that time, there can be a temperature change of IV solution. Okay. There is, as I told you, that patient receive lot of fluids or saline during the procedure. When they receive fluids, there is change in temperature of the IV solution, and when there is change in temperature, you will get a variation in the waveform, and then you don't have to panic at this time. You just re-zero the system and restart it. Okay. So this is how you will sort the waveform drifting. Then, if you are unable to flush the line with a continuous flush system, okay, let's say your flushing system, your pressure bag is a problem, then check the stopcock first. Check if your circuit is open properly, and check your tubings if any of the tube has got any kink. If there is no kink and still you're getting it, there might be some obstruction which you cannot see. You just have to change the line. Okay. Then check to see if the pressure bag is inflated at the appropriate level. Now this is very important. You are trying to flush, but there's no pressure in the pressure bag. Then you will not see the saline flushing. So you have to make sure that the pressure bag pressure has got a pressure until 320 bar. Okay, at the 320 bar. Then reposition catheter to move it away from the vessel or to remove catheter kinks. So many times, because the catheter is engaged by rotating, and that rotation may cause some sort of kinking. So you just move the catheter away and just try again for flushing. Okay. Then aspirate with a syringe. I told you that always aspirate, never flush it inside if you're having any problem with any kind of pressure recording. Okay. Always aspirate, never flush inside. Okay. Any problem that will come out, but any problem which will go inside will cause a problem for a patient. It can be clot, it can be air bubble, it can be anything. Okay. Then if you are getting readings very high readings, then sometimes what happens is the diastolic blood pressure is above 120, 140. Then that is a time where your transducer has not been zeroed or not been calibrated properly. Okay. So check the transducer whether the position is proper, and then re-zero it. Okay. Then check the stopcocks if they are open towards the patient, and then record the pressure. Then check the flow rate of automatic flush. If the flow rate of automatic flush is too high, then it will show you the higher pressure. So the flow rate, a standard flush device should deliver 3 microdrops per minute. So the flow rate should be very less, okay, from the transducer. If the flow rate is very high, then you might see a very high pressure, because the pressure is generated from both pressure bag and from the patient, and transducer gets confused to show the pressure, and the pressure will not be accurate. Okay. Then if the reading is too low, check if the transducer is located. Again, if the reading is too low, then pressure transducer will be located probably higher than the patient's mid chest level. Then check for loose connection. Sometimes you have connected everything is open, you are seeing some sort of pressure, but the connection is loose. So if you have a loose connection, you will not see accurate pressure. If there are air bubbles, you will see a low pressure. So your tubing line, your catheter line has to be flushed, and it has to be air free completely to record any sort of pressure. Okay. Then if you have an overdamping waveform, check for air bubbles in the system. Okay, there can be a kink again or blood in the system. Okay, then there can be a suspected occlusion, catheter tip. So all these uh, troubles can be shooted when you know what has to be done for what kind of problem. Okay. Now this is a cath lab system where the hemodynamic monitoring is done. You can see not many of the people are inside the cath lab due to radiation exposure. So if a person's job is only to monitor a hemodynamic assessment, they can sit outside and they can communicate through a mic from inside. Okay. So as you can see, a technologist or a physiologist is responsible to monitor this pressure recording during the procedure, and the cath lab procedure is done inside. Okay. Now let's come to hemodynamic data now. Now we know about transducer, we know about what to do, what not to do, and what how to troubleshoot the waveforms. Now we should know about the waveforms. Now the word hemodynamic is derived from a Greek word. So that means blood and power. Okay. So hemo is blood, dynamic is any power. Okay. So meaning blood movement, which is studied, or blood circulation, which is studied. Okay. Then I'll just go through briefly with this normal blood circulation. So in our heart, there are two types of circulation. One is pulmonic circulation, one is systemic circulation. Pulmonic circulation, where all the unoxygenated blood is collected and it comes through superior vena cava, inferior vena cava, and it comes to right atrium, then goes to right ventricle and goes to pulmonary artery, where it then goes to lungs and there it gets purified. Then your systemic circulation starts from lungs. It comes to from pulmonary veins. It comes to left atrium, then left ventricle, from and then to the aorta and to the other body parts. So when we say systemic circulation, meaning the blood flow is going to all the body parts, all the systems. When we say pulmonic blood flow, that means blood is coming from all the system to the pulmonary system or to the lungs to get purified. Okay, so we should always remember our normal blood flow pattern or normal blood circulation. This is very important for any kind of hemodynamic assessment or any diagnosis if you want to make during the hemodynamic assessment. Okay. Now you must have seen waveforms very commonly. You know what is normal blood pressure, but there are different waveforms, different pressures in the heart chambers. So we'll go step by step. So left heart, we have left atrium, left ventricle, and aortic pressure. And in right heart, we have right atrium, right ventricle, pulmonary artery, and pulmonary capillary wedge pressure. So we'll go one by one and we see how the waveforms look, what is the normal pressure for these cardiac chambers. Okay. So let's start with left heart catheterization. First, we'll see aortic blood pressure. Now, if you see this slide, this is a waveform, which is the aortic blood pressure waveform. Okay. This is what we record with the blood pressure cuff. Normal range systole is 100 to 140. Diastole is 60 to 90. Now, if you see this waveform carefully, there is one peak and one trough. So peak is systole and trough is the diastole. Okay. And there is a notch in between. This notch is called as dicrotic notch. Okay. This notch signifies that there is a closure of aortic valve, and during the closure of aortic valve you get this notch. So when you get a pressure waveform with this notch, it is an aortic pressure recording. It is a pressure from the aorta. All right. So this is a sign to identify the pressure, that what pressure it is. Secondly, this pressure waveform will be always recorded at 200, always recorded at 200 millimeters of mercury scale. Okay. And the pressure waveform will be always higher. Okay. So this is systole, this is diastole. You can see we are getting reading at every point. systole, diastole, and there will be a straight line in between. That is your mean pressure. Okay. So that was aortic blood pressure. Now, similarly, we have left ventricular pressure. Now, if you see this curve, this is different than the aortic pressure curve. This pressure is low in diastole. So normal systolic pressure is similar to the aortic systolic pressure, but the diastolic pressure is low. So normal range for LV systolic pressure is 100 to 140 and diastolic pressure is 2 to 12. Okay. And here is the pressure waveform. This is the peak, which is the systole, and this is the diastole. And if you see this point, this is LV and diastole, and this is important in patients with coronary artery disease, cardiomyopathies, or any pericardial diseases. We monitor this end diastolic pressure. As you see, normal is 2 to 12. If it is above 12, it is elevated. Okay. Excuse me. Then we'll come to right heart catheterization. We have pressure from right atrium, we have pressure from right ventricle, pulmonary artery, and pulmonary capillary wedge pressure. Let's see how they look. Excuse me. Now, if you see this waveform, this is the RA pressure curve. You might get confused that there are so many waveforms and there are so many curves. In any of the atrial cardiac chambers, we always see the mean pressure. We never see systole and diastole. The reason being, the pressure in atria is very low to get any systolic or diastolic pressure. So in atrium, we always get the mean pressure. So right atrium mean pressure is normally 1 to 7 mmHg. And the waveform here starts like this. So this is first wave A, and then there is a notch C, then there is X, and then there is V, and there is Y. So there is significance of all these waveforms. Okay. So there is A peak and V peak. So there are two peaks for the atrial pressure waveform. Okay. So two peaks. One is A peak and one is V peak. So A peak is formed when there is rapid atrial filling. Okay. Rapid atrial filling. Okay. Or you can say rapid atrial contraction. Okay. Then C is due to closure of cusp. And X is when atria is relaxing, atrial diastole. And V waveform is when there is venous filling from superior vena cava and inferior vena cava, there is V waveform. And Y, when there is emptying of this blood from the atrium. So various phases of cardiac cycle are showing us various pressure waveforms. What we are interested is just on one mean pressure. There are two peaks, A and V, which has their own significance. Now, if you notice, the pressure scale here is very low. As the normal pressure is 1 to 7 mmHg, we should keep our scale of 25 or 30 to record this pressure. Okay. Then we have right ventricular pressure. Now, if you see the waveform here, it is quite similar to the LV waveform, but the end diastolic waveform is a little bit different. Okay. But the big difference is the range. The LV and the RV waveforms may look similar, but the range is different. The RV systolic pressure is not more than 30 mmHg. So the range is 15 to 30 mmHg. And normal diastolic pressure is same as RA pressure, 1 to 7 mmHg. Hence, our pressure scale should be 50 or 30 to record this pressure waveform. Okay. So always make sure, because the right-sided heart chamber are carrying the venous blood. Okay. The pressure is lower in the right side of the heart because they are at the receiving end. Okay. They are not at the giving end. They are at the receiving end. And you have to if you need to receive anything, your pressure has to be less. So they are at the receiving end, and hence the pressure in the right-sided cardiac chamber is less, whereas in left-sided cardiac chambers, they are delivering, they are pushing it out, and hence the pressure is very high in there. Okay, so the pressure in RV is about 15 to 30 systolic and 1 to 7 diastolic. Okay, but the waveform is similar to the LV waveform. Now this is the systole, this is diastole, and this is the end diastole. There are cases, excuse me, there are cases where the end diastolic pressure is important, like patients in constrictive pericarditis, patient in cardiac tamponade, where we diagnose and differentiate between cardiomyopathy and constrictive pericarditis. Okay. Now, if you see pulmonary artery pressure, now if you remember the aortic pressure curve and you see this pulmonary artery pressure curve, they both look similar. Okay. Both great arteries, aorta and PA, the waveform is similar. Both ventricles, LV and RV, the waveform is similar. Both atriums, LA and RA, the waveform is similar. But the difference is the aortic pressure scale is very high. It is 120 and 80. Normal is 100 to 140 systolic, and diastolic is 60 to 90. Whereas pulmonary artery pressure is systolic of 15 to 20 and diastolic of 6 to 12. Okay, so there is the difference. The pressure is still low in this side, although the pressure waveform is same, but don't get confused because the pressure is less in the pulmonary artery. Okay, so your pressure scale for right heart measurement is ideally should be 50. Okay, for atrias it should be 30. For ventricles and aorta it should be 200. Okay, then as I was telling you that the waveforms in two cardiac chambers are same. So if you see the RA, the waveform is A, C, X, V, and Y, which is similar. In left atrium also there is A, C, X, V, and Y, which is similar. But the only difference is the V wave in the right atrium pressure is less than the A wave. Okay, the A peak is usually higher than the V peak. Okay, but the V peak is either similar to A peak or a little bit higher than the V peak in the left atrium. Okay, this is a very important point. Okay, and this is very important question in any of the competitive exams as well, to identify the pressure, whether this is left atrial pressure or right atrial pressure. How you will differentiate? The only way is to see if your A peak is a little bit less than V peak. If their A peak is a little bit higher than V peak, it is left atrium. Now there are conditions like tricuspid regurgitation or mitral regurgitation, where your venous filling is accompanied with the blood coming back from the tricuspid valve or back from the mitral valve, and hence your V peak will increase. Okay, so at that particular point, it is very important that your catheter position, where is your catheter position to record this kind of pressure. Okay, so it becomes very challenging when there is any pathology of regurgitation either at mitral valve or at right atrium. Okay, and hence it is very easy to determine the pressure by the mean pressures. Okay, so we always see right atrial and left atrial mean pressures. Okay, now there is something called as pulmonary artery wedge pressure. Now pulmonary artery wedge pressure waveform is also similar to the atrial pressure, but it will be very tiny, and hence it is very difficult to differentiate between A, C, X, V, and Y waves, and hence we always see the mean pressure. When we say pulmonary artery wedge pressure, that means this pressure is very deep inside the pulmonary capillaries where the blood is getting purified. And even when you go from the right heart, your pulmonary capillary wedge oxygen saturation will be very high as the blood is very pure in there. Okay, so mean pressure is important. Okay, I'll discuss the connections between the chambers. And as I told you that the pressure waveforms of LV and RV are very similar. As you can see, a tall peak and a trough. So a tall peak and a trough, systole and diastole. But the difference is, you can see the scale. This is 140. Okay, this is around 25. Okay, so always it is important. It is very important for you to see the scale first. Check if your scale is at proper level, then your catheter position, then the pressure waveform. Okay. Again, the pulmonary artery and the aorta, both great arteries, the pressure waveform is similar, but you see the scale. This is at 25 scale and this is at 150 scale, and notch is present at both pressure waveform on both pressure waveforms, because this is because of closure of pulmonic valve. This is because of closure of aortic valve. Okay. Then, if you see this diagram, now there are connections. Now this is right heart pressure and this is left heart pressure. Now in right heart pressure, we have pulmonary artery, right atrium, right ventricular, pulmonary artery, and pulmonary capillary wedge pressure. All are at lower scale. All pressures are at lower scale. Okay. Whereas if you see the left atrium, the left ventricle and the aortic pressure, they are at higher scale. Okay. Then there is a connection between these pressure, this pressure in the cardiac chambers. Now, what is that connection? So, the pressure in the right atrium, the mean pressure in the right atrium is very similar to the diastolic pressure of the RV. Okay. Now, this is very important to understand. The mean pressure of right atrium is very similar to the diastolic pressure of the right ventricle. Same goes for mean pressure of left atrium is very similar to the diastolic pressure of the left ventricle. Now you will ask me why it has to be very similar, because blood has to go from one chamber to the other chamber. Okay, if the ventricles will not go this low at the level of the atria, then there is no possibility that the blood will be received from the atrium to ventricle. Okay, imagine if the diastolic pressure was very high, then you cannot receive blood from atria to ventricle, and hence the pressure in the mean pressure of the atrias is similar to the diastolic pressure of the ventricles. Okay, and now the ventricles have to pump the blood to go into the great vessels. Great vessels are pulmonary artery and aorta. Now it is very important. Now pumping is what? Is systole. Okay. Now it is very important for systolic pressures to match, and hence the RV systolic pressure, as you can see, RV systolic pressure is very similar to the pulmonary artery systolic pressure. Okay, RV systolic pressure is very similar to the pulmonary artery systolic pressure. Likewise, the LV systolic pressure is very similar to the aortic systolic pressure. Okay, what happens if the LV systolic pressure is very high and aortic is very less? There will be a lot of rush. But if aortic systolic pressure is very high and LV is less, then you cannot get enough blood in the aorta and systemic fluid. And there is the patients, this is in case of the patients of low cardiac output heart failure. Okay, the LV is not able to generate enough systolic pressure to get the circulation into the systemic systems, and hence this is low cardiac output stage. Okay, so I hope you understood the relations between the atria and the ventricular pressure and ventricle and the great artery pressure. Okay, now this is a table from book Brownwell's Heart Disease, from their chapter, where they have given the correct range of the pressure waveforms which is followed worldwide. As you can see, the right atrial pressure is right atrium mean pressure, which we always follow, is between 1 to 5. RV and diastolic is between 1 to 7. As I told you that the diastolic pressure of RV and the mean pressure of RA is similar. So you can notice here. Okay, and the systole pressure of RV is similar to the systole pressure of PA, 15 to 30. Then pulmonary capillary wedge pressure is mean of 4 to 12 or 4 to 16, which is similar to the left atrial pressure. Okay, left atrial pressure is 2 to 12, which is similar to the end diastolic pressure of the LV, and LV systolic pressure is similar to the aortic systolic pressure. Okay, as you can see that with this chart, we have tried to show you that what is similar to what. Okay, now this is very important. So LV diastolic pressure is similar to LA mean pressure. Okay, this is very important when we do a cardiac catheterization. Okay, I'll explain you how. Now, just if you focus here, LV diastolic pressure is very similar to the left atrial mean pressure. Left atrial mean pressure is very similar to the pulmonary artery wedge pressure. Okay, pulmonary artery wedge pressure is very similar to PA diastolic pressure, pulmonary artery diastolic pressure. Pulmonary artery diastolic pressure, okay, when you see pulmonary artery diastolic pressure, it will give you a rough idea about RA mean pressure. Okay, so even if you are doing an LV end diastolic pressure, you can still estimate what could be the LA pressure, what could be the pulmonary capillary wedge pressure without puncturing vein, without going into the right heart. Okay, because of this particular connection. Okay, now there is something called as oxymetry, oxygen saturation. Now oxymetry is a separate topic, but I'll just cover in brief here because this is important part of hemodynamic assessment. Now it is very important for oxygen it is very important to measure the oxygen saturation or during the cardiac cath procedures, especially if you want to calculate the cardiac output, stroke volume index, all the other things when we go old school method. Okay, so what is oxygen saturation? It is nothing but the oxygen contained by the hemoglobin, okay, and in RBC. Okay, so normal oxygen saturation. So different cardiac chambers have different oxygen saturation. Now it is very obvious. Why? Because some of the chambers are receiving blood which is venous blood, which is impure blood. Some of the chambers are receiving blood which is very pure blood. Okay, now with this chart it will be confusing, so let me take you to the diagram. Now if you see this schematic diagram of heart, you see the right heart receives the venous blood, and hence the oxygen saturation of the blood in the right heart is expected to be low normally. Okay, the oxygen saturation in the right heart is expected to be low normally because they are impure blood, okay, from the other body parts. Now if you notice, the superior vena cava saturation is less compared to the inferior vena cava saturation. Okay, why? Because brain uses more oxygen, and hence the superior vena cava is receiving the blood from the upper circulatory system, the brain and other things, and hence you get less oxygen saturation in the SVC when compared to IVC. Okay, but when both meet, this is 75, this is 70, when both meet at right atrium, we get an average of SVC and IVC in right atrium. Okay, so right atrial, now because the right atrium, the blood from right atrium will go to right ventricle, there will be no change here. So the oxygen saturation from right atrium to the right ventricle is expected to be same. And similarly, the blood from RV will go to pulmonary artery, and hence we don't expect any drastic change, or in terms of cath lab terminology, we call it as step up. Step up meaning higher oxygen saturation from RV to PA. Okay. Now, when you come to left atrium, because the left atrium is receiving blood from lungs and it is a pure blood, the oxygen saturation is expected to be this much. Okay, is expected to be very high, 99 to 100%. Okay, we cannot get 100% because when we do the reading, we take it in catheter, we take it in syringe, okay, and that gets contaminated, and hence we might get just 1% of difference. Although the blood is pure, but we might get the reading of 99%, 98%, or 97%. Okay, so because the blood is moving from left atrium to left ventricle, we expect that the blood saturation should be the same, and similarly it should be the same into the aorta. Okay, now because some amount of blood remains in LV, so we might get a few much maybe a 1% or 2% of difference in the oxygen saturation of LV and aorta, but it is almost similar. Now if at all you get oxygen saturation of 70% and 75%, but in right atrium suddenly you get 85% or 90%, okay, then there can be a connection between left heart and right heart, and there, this is how the diagnosis was made for atrial septal defect back in days where the echo was not very helpful for the diagnostic tool. Okay, so this is how they used to diagnose the ASD. Okay, and then if let's say the oxygen saturation was normal in SVC, IVC, RA, but there was sudden step up in right ventricle, then that can be a cause. There can be a ventricular septal defect, VSD. There can be a connection between two ventricles where the pure blood is coming from here and the ventricle is getting pure blood. If the RA, RV has got impure blood, but suddenly pulmonary artery gets a good saturation of 90%, 95%, then there can be a patent ductus arteriosus, PDA, which is giving blood from aorta to the pulmonary artery and causing the step up in the oxygen saturation. So like this, the diagnosis was made for congenital heart diseases back in days. Okay. Nowadays, the echo is so advanced that cardiac catheterization is not very much in existence, but we still, it is important in patients of mitral regurgitation, mitral stenosis, aortic stenosis, any form of aortic stenosis. So with all this, I just want to conclude here that accurate hemodynamic measurement is very crucial as it will affect the patient prognostic and management strategy. Any error will cause problems for the patient and may lead to morbidity and mortality. Okay, therefore it is very important for you to do this accurately and properly. Okay, you can see that you might feel that, oh, what is my role in this cath lab? I'm not very important person, everything is done by the cardiologist. But no, it is very important. You have got a responsibility of patient's life, and hence you have to do this properly and accurately, and you can do this when you know the things properly. So always practice, get it thorough, and then do the things. Okay, and with this I just want to say thank you very much for this opportunity. um, uh, I hand over this to Sahil, and if you have any questions, I can take your questions.
Any questions?
If you have any questions, I can take it. Otherwise, we can conclude. I hope it was clear and understandable. Okay, Sahil. So I think I hope everyone has understood. I can take only 2 points now. If everything is clear, then I hope they have understood. If is and if they have no doubts, then it's good.
If they don't have the questions, so then please you can ask them the questions.
That is your part. You may ask them questions. Okay. So I've done my part. I've taught them. You may ask them the questions, and if you can, um, I'm sure they should be able to answer.
Anyone has missed something? Please, if questions are there, ask him. I think we could conclude, sir.
All right. Thank you very much, Sal. Thank you for your opportunity. I wish you all the best. I wish all the best to the students. Do well. And
Thank you for
anyway,
your side, sir. Thank you from your side because it is a bit difficult task to take a lecture at 7 in the morning.
no problem. All right. I'll see you guys.
Thank you, sir.
Thank you,
Thank you.
sir.
Thank you.
Thank you. Thank you, sir.
Thank you, sir.
Uh, so, uh, so can we get the recording of this?